Hello everyone. Today we'll be discussing 4 cases of primary diffuse large B-cell lymphomas of the central nervous system. This is a case 1, 60-year-old lady who was brought unconscious to the hospital. Her MRI revealed intensely enhancing mass in the right frontoparietal parafalcine region, which measured 5 into 5 into 3.1 centimeters. Perilesional edema was present. So, the imaging findings were suggestive of glioma with bleed. Case 2 is a 62-year-old man who complained of headache and had hemiplegia, and his MRI revealed 3 lesions, one in the right temporal lobe, another in the right basal ganglion, right frontal, and one in the other 4, one in the right cerebellar hemispheres. So, the lesion in the right temporal lobe was lobulated solid enhancing mass, which measured almost 4.5 into 4 centimeters. And on post contrast, it was enhancing mass. The differential diagnosis suggested by the radiologist were fungal abscess, toxoplasmosis, inflammatory pseudotumor, tumefactive demyelination, metastasis, and lymphoma. Now, the third case is a 60-year-old lady who had headache, behavioral changes, and an episode of seizure. Her MRI revealed oval mass in the left frontal region, which had intermediate signal intensity in periphery and central hyperintense signal. Case 4 is a 60-year-old man who complained of headache, giddiness, and forgetfulness. Again, this patient had multiple masses, one in the right frontal, right thalamus, left temporal, and the mass was intraaxial with altered intensity and measured almost 4.3 into 4.1 centimeters. Peritumoral edema was present. It was heterogeneously hypointense on T2 and isointense on T1. So we did intraoperative squash smears of the second case, and cellularity, it was a highly cellular tumor composed of large discohesive atypical lymphoid cells, and you can see there's mitotic activity evident. And for Romanovsky stains or the field stain, these express the nuclear features very prominently. So I routinely do this in our lab. Coming to histology, these are highly cellular, diffusely growing patternless tumor. Angiocentric pattern is very prominent at times. The neoplastic cells are large or typical with large round to oval nuclei. The nuclei may even have irregular nuclear borders. Nuclear pleomorphism is noted, and a distinct nucleoli is present, which corresponds to centroblasts or immunoblasts, and the cytoplasm is scanty in amount. Brisk mitotic activity with atypical mitotic figures are present. Usually central necrosis is found. The tumor cells are intermingled with reactive inflammatory cells, and sometimes intermingle macrophages with foamy or clear cytoplasm when present with a monomorphic morphology of a lymphoma, may mimic Burkitt's lymphoma. So these is the microphotographs. You can see large or typical nuclei. Some places they are irregular and presence of prominent nucleoli. This is a typical angiocentric pattern, and you can see this is a diffusely patternless infiltrating tumor into the brain parenchyma, and areas of necrosis are evident. So whenever these patients are treated with corticosteroids, especially dexamethasone, prior to imaging findings, the tumor almost vanishes within hours. So a precaution should be taken before doing imaging or before the surgery, because we may not get a representative biopsy of the tumor. Neoplastic B cells are destroyed because of the corticosteroids. causing and falsely elevated levels of the CD3, that is the T lymphocytes, leading to a dilemma whether it should be called a lymphoma. So these cells are then, these tumors are then misdiagnosed as demyelinating disease, and eventually the lesions of the lymphoma flare up. So coming to immunophenotype, these are LCA positive tumors. The B cell markers, PAX5, CD19, CD20, CD22, and CD79 A can be done. These are BCL6 positive in almost 60 to 80%, MUM1 positive in 90%, BCL2 in approximately 82% of cases, MYC is high in 92. These are CD3 T cell negative, and CD10 is helpful to determine whether it's a metastatic lymphoma or the primary CNS lymphoma. The proliferation index is usually 70 to almost 80 to 90%. And in an immunodeficient patient, it is important to get done the Epstein-Barr virus state. We have had one case which was showing Epstein-Barr virus antibody positivity. And now coming to subtyping, whether it is GCB or non-GCB, the markers done for this are CD10 positivity should be present, or when CD10 is negative, BCL6 should be positive, and in the non-GCB type, MUM1 positivity is noted. We should get done CD38 and CD138, which is negative when there is no plasmacytic differentiation. GFAP and OLIC2 is done to rule out small cell glioblastomas, or even anaplastic oligodendrogliomas may look like lymphomas at a times. And cytokeratin should be done to rule out metastatic carcinomas. So this is the immunoprofile. Primary diffuse large B-cell lymphomas of the central nervous system account for less than 3% of all brain tumors and 4 to 6% of all extranodal lymphomas. They can occur in any age. However, the peak incidence is found in 5th to 7th decade, and in our last 4 cases, we saw almost all patients were in their 60s. Male have slightly more preponderance. On imaging, they are T1 hypointense and T2 iso2 hyperintense. Dense enhancement is noted on post contrast, and the diffusion weighted images show restricted diffusion. Whenever there is meningeal involvement, it is noted as hyperintense enhancement, and peritumoral edema is present but is relatively limited and less severe than in malignant gliomas and brain metastasis. This helps us differentiate it. And one must always take the history of administration of corticosteroids. As I already said, that the tumor vanishes or shrinks in size within hours. So the DDs on imaging are toxoplasmosis, multifocal glioblastoma, and metastasis. In immunocompetent patients, these lesions usually appear homogeneous, and in the immunocompromised patients, these lesions are heterogeneous due to hemorrhage and necrosis. Localization now, the solitary brain lesions account for 65%, and the multifocal lymphomas, they account for almost 35%. The most common site is the cerebral hemispheres, followed by thalamus basal ganglion and corpus callosum. Leptomeningeal involvement may be present, and 20% of patients have ocular manifestations. Macroscopy, these are single or multiple masses in the brain parenchyma. They're firm, friable, granular hemorrhagic masses, and grayish tan or yellow in color with central necrosis. Other investigations which we can do is the CSF cytology, which will show raised counts, that is pleocytosis, and there will be evidence of atypical lymphoid cells. A combination of cytological and immunohistochemical analysis with multi-parameter flow cytometry can be done, and in other routine investigations you can get done CBC with ESR and serum LDH levels. PCR demonstrates clonal rearrangement of IgG with introduction of somatic mutations. This is basically a very aggressive tumor, and the other lymphoid neoplasms of the CNS are low-grade BSL lymphoma, which is not as aggressive as DL, diffuse large B cell type. T cell and NK T cell lymphomas, these are aggressive tumors. Lymphomatoid granulomatosis is usually associated with Epstein-Barr virus. The intravascular large B cell lymphoma, this is aggressive type, and the primary marked lymphoma of the dura. These mimic meningiomas, and these have better prognosis. So this central CNS, DL, diffuse large B-cell lymphoma, these have worse prognosis than the systemic lymphomas. In adult patients, these patients do better and they may be cured. But the older patients, especially those more than 65 years of age, have shown reduced survival with increased risk of neurotoxicity. Uh, Coming to treatment, high dose methotrexate based on polychemotherapy is administered. Inclusion of consolidated whole brain irradiation may improve progression-free survival, but not overall survival rate. So thank you very much.